First of all, coronary arteries are the vessels that actually provide blood flow and blood supply to the heart of the muscle, the heart muscle. There are three main arteries that we look at: the right coronary artery, the left main, which branches into the left anterior descending artery, and the circumflex arteries. When you have disease or blockage in these coronaries, obviously blood flow to the heart muscle in that region is compromised, and you can have chest pain, heart attack, and problems with blood flow to your heart. Now, if you had one vessel or perhaps two vessels that were blocked, the interventional cardiologist could put a little stent in it. It's a metal stent that they actually open up the lesion with. But in patients who are diabetics, or when multiple vessels are involved, or where the function of the heart is poor, surgery is actually better than having one or two stents. Coronary artery bypass grafting is a very common procedure that CTSA does. We do it in the conventional way as well as the more innovative, minimally invasive way as well. So I mentioned the indications for surgery: diabetes, multivessel coronary disease, not amenable to percutaneous coronary intervention, ventricular function that's depressed, that actually require surgery at this time. So those are the indications for bypass surgery. Now, the concept behind coronary artery bypass surgery is different from a PCI stent. A stent is actually it's a little metal stent that opens up the lesion itself. Bypass surgery is a bypass operation where you take conduits from other parts of the body, whether it's the internal mammary artery off the chest wall, could be the radial artery off the forearm, and maybe veins from the leg, and we basically plug these conduits into the target vessels beyond the blockage to get blood flow to the target muscle, which is the end organ. So the conventional form: open up the breastbone, put you on the heart-lung machine, and then do the bypasses. Separate you from the heart-lung machine, close the breastbone. That's the conventional CABG operation. The minimally invasive approaches are actually twofold. There's one where you actually open up the breastbone, and then you can do the bypass operation without the heart-lung machine, where the heart is actually beating. When it beats, you stabilize where your target vessel is going to be, and you put your conduits on it. It's called off-pump coronary artery bypass grafting, and we do that as well. The other minimally invasive operation for CABGs include a mammary artery that's taken off from the side of the chest, not from the front. So you avoid opening up the breastbone. So from the side, you take the mammary down and you plug it in with the heart beating onto the artery. That's actually for patients who only need maybe one or two vessels. And taking off the mammary can actually be done robotically as well with the Da Vinci robot. So hybrid revascularization procedure combines the best of both worlds. The interventional cardiologist stents any of the blockages that are in the non-LAD arteries, and we go ahead and put a mammary artery onto the LAD, which is the most important graft actually in terms of survival. Risk of bypass surgery can vary depending on patient's comorbidity, patient's anatomy, patient's ventricular function. And obviously not one person is exactly the same, but I would say in general, coronary artery bypass grafting operative risk is less than 5%. Hospital stay is about 5 days, maybe less. The recovery period for coronary artery bypass grafting is about 5 days as well. Usually patients feel great after their bypass operation, may perhaps day 1. Again, there is pain related to the incision itself. The rest of the hospital stay is the cardiac rehab that we initiate on the floor.